An integrated model of preeclampsia, a multifaceted syndrome of the maternal cardiovascular-placental-fetal array. Controversy surrounds the etiology of preeclampsia. Some groups posit that it stems from maladaptation of the maternal cardiovascular system, while other groups more traditionally view the placenta as the source of the disease. Here we present an integrated approach that merges these two viewpoints. Caramanchi and colleagues started a revolution in preeclampsia research almost 2 decades ago with their seminal work on S-FLT and its role in preeclampsia. S-FLT, in its soluble circulating form, blocks attachment of PLGF and VEGF, reducing the effect of PLGF on target cells of the cardiovascular system. We showed 12 years ago that S-FLT is found in maternal blood vessels of the maternal-fetal interface. Angiogenic and anti-angiogenic factors are balanced. Pro-angiogenic factors prevail in normal pregnancy, while an overabundance of anti-angiogenic factors leads to preeclampsia. The leading investigators in the placental origins of preeclampsia include Chris Redman and Graham Burton in the UK and Jim Roberts in the USA. Their work hinges on the notion that deficient PLGF leads to endothelial damage, oxidative stress, and the preeclampsia cascade. On the other hand, we have Baski Thaliganathan and Chris Lees, who posit that it is maladaptation of the maternal cardiovascular system to the demands of pregnancy that leads to preeclampsia. Pregnancy is indeed a time of maternal cardiac adaptation, measurable in increased cardiac output, for example. Many groups, among them Baski's, have demonstrated the differences in maternal cardiac structural and functional changes happening in normal pregnancy and early and late onset preeclampsia in mean arterial pressure, total vascular resistance, ventricular remodeling, and other measures. So we seem to have a chicken or the egg conundrum regarding S-FLT. Does excess S-FLT cause the hypoxia that leads to preeclampsia? Or does hypoxia cause an increase in S-FLT and all the signs and symptoms of the disease? Baski's group point to the case of abdominal pregnancies as supporting their hypothesis because there is increased flow in the uterine arteries despite the absence of invasion or conversion of the endothelium by extravillous trophoblasts. They view this as proof that the placenta cannot be the source of preeclampsia. According to their model, all the maternal and fetal signs and symptoms of preeclampsia appearing in other maternal organs, as well as fetal growth restriction, result from maladaptation of the maternal cardiovascular system. However, conversely, there are other examples, such as trisomy 13, which demonstrates that there is no connection to the maternal heart, rather a pathological placenta, with a resulting very high rate of preeclampsia as compared to euploid pregnancies. Another example is that of molar pregnancies, which lack a fetus altogether. Here it is very hard to hang the blame on the maternal heart. Smoking is known to cause long-term damage to the heart, yet pregnant smokers are at a lower risk of preeclampsia. They have higher levels of PLGF and lower S-FLT, which are protective from preeclampsia. In a case from our center of twins discordant for fetal CNS anomaly with severe early onset preeclampsia, S-FLT levels dropped and the maternal syndrome disappeared following selective feticide of the affected twin. We have also collected a cohort of second and following pregnancies from our center who suffered from preeclampsia following healthy first pregnancies. These two examples cannot be explained by maternal cardiovascular maladaptation. Rather, they indicate the essential involvement of the placenta. First pregnancy is an outlier among placenta risk factors. Why should first pregnancy be more prone to preeclampsia? As we showed in our 2019 paper in this journal, decidual NK cells and others undergo a process of training during first pregnancy. They remember pregnancy and function with greater efficiency, leading to more robust implantation in subsequent pregnancies. This demonstrates again that it is not the maternal heart, but the physiology of the maternal-fetal interface which is implicated in preeclampsia. Having said that, there's no question that the maternal cardiovascular system undergoes a process of conditioning during pregnancy. The maternal heart also remembers pregnancy and shows improved function in subsequent pregnancies. These issues are far from resolved. Which brings us to the work of Valenci's, who observed that early onset preeclampsia is more often placenta-mediated, while late onset preeclampsia was more likely associated with maternal constitutional risk factors. However, among formerly preeclamptic women who became pregnant again, the women who developed preeclampsia a second time and those who did not differed significantly in their pre-pregnancy cardiac parameters. It has also been shown that metabolic syndrome is more common toward the end of pregnancies affected by preeclampsia, which may also point to involvement of the maternal cardiovascular system in the development of the disease. The most important work contributing to this debate to date is the groundbreaking work from the Anne Croy lab, which showed that mice with knockout for PLGF developed preeclampsia. It is important to note that not only did the placenta function poorly, but the left heart also failed to undergo normal adaptation as compared to controls, meaning PLGF is essential for placental function and remodeling of blood vessels at the maternal-fetal interface, as well as for maternal heart adaptation. This was further shown by a large study from Holland that demonstrated that women with low PLGF during their pregnancies, even without developing preeclampsia, were more likely to show poorer cardiac measures even 6 and 9 years later. So as we see, the etiology of preeclampsia is a complex amalgamation of factors. The fetus and placenta impact the mother by providing progesterone, estradiol, SFLT, and PLGF, while the maternal side impacts the developing placenta and fetus with increased cardiac output and decreased vascular resistance to supply sufficient oxygen and nutrients. Disruption in any component or nexus of the array or the commensality among them may lead to the multifaceted syndrome of preeclampsia. Full understanding of the intricate maternal cardiovascular placental-fetal array is essential to refining the diagnosis, treatment, and long-term follow-up of women with preeclampsia, including incorporating effective clinical testing in post-preeclampsia patients to confirm or exclude cardiovascular injury to commence early interventions to prevent heart disease.